framework. It's scaffolding. So we're going to teach you what to do for hormones. Remember, to gather, not only do you gather yourself, you gather information, and now you're going to learn the questions you're going to be asking, the hormonal focus. You'll get that in each lecture today. I'm going to teach you how to organize the ATMs and organize what's going on both within the communication node and how that affects other nodes and how other nodes affect the hormonal axis. And I've got a bunch of slides coming up to explain some of that stuff to you, and I hope you're all excited, or as excited as I was when I first heard this stuff. So you can tell I love hormones. Like, it's really the right thing for me that I run the hormone module, because I just think this is really great stuff. So you then use it, and then you tell the patient's story. And I have to tell you that the tell really is the most powerful part of the visit. And putting on this practice implementation hat, if you're ever feeling guilty about charging money, when you go through the tell, I always say to my patients, so do you feel like I understand what's going on with you? And they're like, oh my God, absolutely. I've never, ever felt any other doctor has understood it this way. And then I say, well, how do you feel about our plan? And they're like, it's perfect. So the tell, and that when you and then by the end of the day, you'll be able to integrate everything you've learned from the patient's story to any hormonal imbalance. And then you learn how to order your priorities. Again, that's what you're going to get in the last two talks tomorrow. So, what I'd like you to do now, and this is one of my favorite parts of the morning, is our ability to interact with each other. So, I'd like you to pair up into groups of two, and if you can't do a two at your table, then do a three, but just pair up. And the question that we're going to be asking is, can you think of any connections between ATMs and hormones? Stress, as we know, can be an antecedent, a trigger, or a mediator. Stress causes elevated cortisol, which leads to immune suppression and increased risk for infection. So, what I'd like you to do is talk about ways that you can identify connections between ATMs, hormonal effects, and dysfunction. So let's talk about hormones and the matrix. So the mental, emotional, spiritual, I told you, is so key. Sex hormones have neurosteroid effects. They impact mood, depression associated with low thyroid, antibodies, changes in sex hormones. Meditation helps. What about if we give hormone? Again, you'll hear about that specifically in each of the sessions this afternoon, especially when we're talking about giving sex hormones for cognition, memory, or cognitive decline. What about immune? We all know about stress causes a problem with immunity. So acute stress can actually be beneficial. Chronic stress suppresses both cellular and humoral immunity. If you're a surgeon here, you don't want your patients stressed preoperatively. Too much stress leads to increased disease of almost all types. Elevated cortisol slows wound healing. Maternal elevated cortisol changes programming of the HPA axis. So another hat that I wear is all about prenatal programming. Go to birthpsychology.com if you're interested in thoughts, feelings of moms, either preconception or during pregnancy, and how that affects physiology. The energy node. I told you, sex hormones, steroid hormones made in the mitochondria, but thyroid and epinephrine affect ATP production. Thyroid and steroid hormones actually target mitochondrial genes, so thyroid is intimately involved in mitochondria and energy. What about the biotransportation and elimination node? How estrogen is degraded impacts breast cancer risk, because estrogens, if they're eliminated in an unhealthy way, will increase breast cancer risk. And that has nothing to do with the total amount of estrogen. You'll learn about that this afternoon. You'll learn about the fact that it's the cytochrome P450 system. So we have a genetic predisposition to how we're going to degrade our estrogen, but that genetic predisposition is totally changeable through lifestyle interventions, through functional medicine interventions. So we can take someone who has a very high risk of breast cancer and decrease that risk of breast cancer by improving the way they metabolize and digest their estrogens. A lot of that has to do with methylation, by the way, as well. So we'll talk about that again with Dr. Warner later. High urinary cortisol, usually from stress, predicts heart mortality in a 6-year span. And what you can do is you can go from low risk of cardiovascular risk factors, add in an elevated cortisol, and you now go up a notch in your risk factor level. So you can go from low risk to medium or even high based on your cortisol. And I have patients at high risk for heart disease because they've got family history and their cholesterol profiles aren't great, and or their lipid profiles, and we do subfractionization, we do everything, and really the cortisol is where they want to start because it's usually from stress. Stress is usually from some sort of imbalance in their life, and they'd like that fixed in addition to their cholesterol. Transport. So you know about thyroid hormone and how important that is for clearing cholesterol. And low testosterone is associated with arterial stiffness, and estradiol actually can help arterial stiffness. So again, that's within the communication node, and how when we have that higher cortisol, and that leads to, as I said, the deaths from cardiovascular disease and insulin resistance metabolic syndrome. That also happens when you're hypothyroid. So throw in stress and hypothyroidism, and it's a double whammy for insulin resistance. And would you be surprised to know that stress also causes insulin resistance? And that cortisol exposure downregulates those cortisol receptors. So that's two ways that cortisol receptors can be impacted. One is by prolonged stress, and the other is a genetic issue. Bone health. HRT reduces postmenopausal osteoporotic fractures, and low testosterone, low T, is a cause of osteoporosis in men. And there's a new article out about osteoporosis. This just came out this week about osteoporosis relating to stress hormones. And so there's again a link within the hormone node. Intestinal permeability can cause ovarian inflammation and impair progesterone synthesis. Now, that's one little bullet there that I can spend 20 minutes talking to a patient about. Why we're doing a gut repair regimen when they're coming in with anovulation, or when they're coming in with infertility, or when they're coming in with a desire for preconception. Gut. I talked to you about estrogen metabolism and how we eliminate estrogen. Well, the microbiome helps determine, it's one of the determinants of a healthy versus an unhealthy microbiome. Save this slide, look at it, because it shows how everything relates in hormone world. Or everything starts with cholesterol, rather, We can form cortisol, we can form our androgens, we can form our estrogens. And what we end up forming has to do with the tissue we're in, because the tissues have different enzymes. So the reason the ovary doesn't make cortisol is because it doesn't have the enzymes to do that. So, the 5 initial takeaways. These steroid hormones come from cholesterol, and so if there's not enough calories or enough fat, or statins make LDL too low, that'll be a problem. The action occurs in the mitochondria, so mitochondrial health is key. We talked about sex hormone binding globulin, how it's important to understand how that is working in your patient, and how enzymes change them. That's why we just talked about the enzymes that are affected by insulin, or aromatase, or methylation happening. And the ATMs, stress, toxins, nutrients, modulate these enzymes. So changing ATMs, as well as the bottom of the matrix, you can lead to changes in the hormones without giving hormone replacement. And this slide is so important because you have this handout. This talks about the nutritional ways that we can modulate these pathways. The plus means that the items spoken about enhance the enzyme activity. The minus inhibits enzyme activity. And so, for example, if we're looking at aromatase, where androgens go to estrogens, how soy and resveratrol and flax lignans are aromatase inhibitors, green tea. So this is how we modulate the steroid pathway, or how it's modulated. So the walkthrough, we start with cholesterol. And then you're going to see we go to pregnenolone. But the way we get to pregnenolone is through the mitochondria, through the inner membrane of the mitochondria. That's the rate-limiting step. That enzyme is called P450-SCC, and that forms pregnenolone. We have to form pregnenolone. Once we form pregnenolone, we can either go down to progesterone or make DHEA. And if we're making DHEA, it's arbitrarily called the delta 5 pathway, progesterone the delta 4 pathway. So the body makes a choice based on where we are, which tissue. So again, 2 different pathways, 5 or 4. If it forms progesterone, it becomes 17-hydroxyprogesterone, which then becomes an androgen, which then becomes an estrogen. So progesterone, 17-hydroxyprogesterone, can become an androgen or an estrogen, and actually, it can go down there too. Androstenedione then forms testosterone. Both can be turned into estrogens by aromatization. So just remember, androgens become estrogens through the enzyme aromatase. That's the key takeaway. Androstenedione to E1, testosterone to E2. I say familiar to familiar, testosterone to E2. So here you see androstenedione and testosterone becoming the estrogens. And just when you think you got it, as I said, the 17-hydroxyprogesterone can also form cortisol, and progesterone can also form aldosterone. So if your body needs cortisol or aldosterone, what happens? Less progesterone is circulated because it's shunted away. Now you're going to hear us use the term shunting, stolen, etc. That's just to help you understand it. That's a teaching tool. What really happens is that the cortisol inhibits enzyme synthesis, both at the hypothalamus and the pituitary, and actually at the level of the ovary or the testes to make less sex hormone. So we call it a cortisol steal. So think of it as needing to make cortisol or aldosterone. You make that cortisol and you don't have the sex hormones. So then you have less progesterone initially. That leads to an estrogen dominant state. There's now some literature about that recently about breast cancer risk, fibroids, endometriosis. Long term, it's decreased formation of sex hormones, and this is one of the reasons that we have stress that's associated with hot flashes and stress that's associated with low libido. So it's not this literal cortisol steal. The biochemistry, as I said, is more complex, and it stops sex steroid hormone production. So the physiological effect of that cortisol steal is stress leading to increased cortisol, stress leading to less sex steroid hormone, and the 1720 lyase enzyme being inhibited, as we talked about in that question, and that's what's called the cortisol steal. If it takes the aromatase route, this route, the number 5, and we form DHEA, that can be converted into androstenedione, which can become testosterone or estrone. The takeaway here is if people are being given DHEA or actually taking DHEA because it's OTC, they can be raising sex hormone levels. I had a patient who came in taking a lot of DHEA, and I believe that led to a recurrence of her breast cancer. So DHEA can increase testosterone and estrogen. That's the takeaway here. Because you see,